Hello, esteemed master and practical class members. Before we begin today's discussion on sacroiliac joint pain, I would like to start by asking you a few simple questions. In your own clinical practice, how many patients actually improve when you perform only a sacroiliac joint block? Not in theory, but in real life. If you look back at your patients with low back pain, what proportion truly respond to an SIJ block alone? Second, when you suspect sacroiliac joint pain, do you routinely perform the 6 physical provocation tests, and if 3 of them are positive, do you proceed to a diagnostic block? Many textbooks recommend this approach. But in real clinical practice, how consistently do we actually follow that pathway? Third, when a patient points to a specific painful area, do you pay attention to the pain distribution pattern? Do you record it, analyze it, or use it as part of your diagnostic reasoning? And if you do observe the pain distribution, how do you actually use that information when making clinical decisions? These questions are important because sacroiliac joint pain remains one of the most difficult diagnoses in spinal pain medicine. Physical examination is often unreliable. Imaging findings are frequently nonspecific. And even diagnostic blocks have limitations. In this context, one of the most frequently cited references is the pain distribution map developed by Professor Hyung-il Kim's group. Based on block-confirmed cases, this study classified the pain patterns of sacroiliac joint arthropathy and proposed what is known as the Pain Distribution Pattern Template, or PDPT. This map has become one of the most widely referenced clinical guides when discussing sacroiliac joint pain. However, if we look carefully at the original study, the mechanism behind these referral patterns is not clearly explained. The map shows us where the pain appears, but it does not fully explain why these particular patterns occur. Over the years, while observing patients with sacroiliac joint pain, I began to notice that these patterns seem to reflect different underlying pain generators within the sacroiliac joint complex. So today, rather than simply presenting the map itself, I would like to share a mechanistic interpretation of these patterns, based both on the original study and on clinical observations accumulated over time. In other words, we will try to understand not only where the pain appears, but also what anatomical or pathological process may be producing each pattern. First, let us briefly review the types in Kim's pain distribution map. The map classifies sacroiliac joint pain into several characteristic patterns. Type A represents the classic gluteal pain pattern. The patient usually points to the buttock region, often near the PSIS. This is the most familiar and intuitive presentation of sacroiliac joint pain. Type B shows a pattern extending more anteriorly, including the inguinal or anterior pelvic region. This pattern is harder to understand if we consider only posterior ligament pain. Type C represents the bilateral ischial pattern, in which patients describe pain over both ischial regions, often particularly when sitting. Type D is the lateral hip pattern, which can easily be mistaken for greater trochanteric pain or gluteus medius related symptoms. Now, rather than simply describing these patterns, we can try to interpret them through the concept of pain generators. From a pathological perspective, sacroiliac joint pain can be broadly understood through 3 major generators that have been demonstrated in the literature. The first generator is inflammatory sacroiliac arthropathy with subchondral bone marrow lesions. MRI studies repeatedly demonstrate findings such as subchondral bone marrow edema, synovitis, and capsulitis in patients with sacroiliac inflammation. These subchondral bone marrow lesions are not merely radiologic findings, they represent active inflammatory sacroiliitis, and the primary pain mechanism is likely subchondral inflammatory bone pain. Because the sacroiliac joint plays a major role in transmitting body weight from the spine to the lower extremities, this type of lesion tends to produce pain that is aggravated by walking or weight-bearing activities. Repeated compression and shear forces during standing and walking may therefore provoke this type of bone-related pain. The second generator involves the posterior ligament complex, particularly the interosseous sacroiliac ligament and the dorsal sacroiliac ligament. The importance of these structures is well recognized clinically. Numerous studies have shown symptom improvement after posterior periarticular injections, and there is also extensive literature reporting successful outcomes after radiofrequency neurotomy targeting the dorsal sacral lateral branches. In this context, posterior ligament lesions can be considered a major extra-articular pain generator of the sacroiliac joint. This type of pain often corresponds to the type A gluteal pain pattern. When a patient clearly points to the PSIS region, sometimes referred to as the 14-finger sign, the likelihood of posterior ligament-related sacroiliac pain becomes higher. There are also characteristic dynamic factors. Posterior ligament pain is often aggravated during sitting or pelvic flexion postures, because these positions may increase tension within the posterior ligament complex. In such patients, treatments directed toward the posterior interosseous or dorsal sacroiliac ligament region may be more effective than intra-articular injections alone. The third generator involves anterior capsular lesions of the sacroiliac joint. Although this mechanism is discussed less frequently, it has been demonstrated in imaging studies. Sacroiliac arthrography has shown anterior capsular leakage, and MRI studies have described findings consistent with capsulitis in the anterior sacroiliac region. Therefore, anterior capsular pathology should be understood as true joint pathology. When inflammation extends through the anterior capsule, the pain pattern may differ significantly from the classic gluteal presentation. Because the anterior sacroiliac capsule lies adjacent to the presacral space, where the superior hypogastric plexus is located, irritation in this region may produce a more vague, bizarre, and poorly localized pelvic discomfort, rather than a well-defined buttock pain. It is important to note, however, that clear and sharply localized inguinal pain in clinical practice often turns out to be hip pathology rather than sacroiliac joint pain. Therefore, there is likely a distinction between true groin pain originating from the hip joint and vague anterior pelvic discomfort potentially related to anterior sacroiliac pathology. Finally, we should consider the bilateral ischial pain pattern, corresponding to type C in Kim's map. When patients complain of pain over both ischial regions, especially in chronic cases, one possible explanation is central sensitization. Persistent nociceptive input from the sacroiliac joint may lead to prolonged dorsal horn activation and neuroinflammatory changes, including astrocyte-mediated sensitization. Over time, this may allow pain perception to spread beyond the original unilateral generator, producing bilateral symptoms. In these cases, the response to a diagnostic sacroiliac block may not be immediate or dramatic. In other words, a false negative diagnostic block can occur. Therefore, when patients present with bilateral ischial pain, clinicians should be cautious about dismissing sacroiliac involvement too quickly. Instead, these patients may require time-dependent treatment and gradual modulation of the pain system, rather than expecting immediate relief from a single diagnostic injection. In summary, sacroiliac joint pain may arise from several distinct generators. Subchondral inflammatory bone lesions tend to produce weight-bearing pain. Posterior ligament complex lesions commonly produce the classic gluteal pain pattern, often aggravated by sitting. Anterior capsular lesions may produce vague anterior pelvic discomfort rather than clear buttock pain. And bilateral ischial pain may represent a more chronic state involving central sensitization, where diagnostic blocks may not produce immediate responses. Seen from this perspective, the pain distribution map is not merely a descriptive diagram. Instead, it becomes a clinical tool that reflects different sacroiliac pain generators and their dynamic behavior. The original map tells us where the pain is located. What we add through clinical reasoning is an understanding of what kind of pathology may be producing that pattern, and how that knowledge may guide us toward the most appropriate treatment strategy. Thank you for watching. It is my honor to be with you. As esteemed premium members, your support greatly motivates my journey of practical pain management on YouTube. I look forward to seeing you in the upcoming videos.